Today I have been asked to talk about neuroendoscopy for intraventricular hemorrhage, which is a very particular technique. I know that this kind of surgery is not very spread around neurosurgical departments, but hopefully at the end of my talk, I will convince you that it is something that we have to learn for the benefit of our patients. I have this disclosure, which is not relevant for the topic. We know from the literature and also from our own daily experience that intraventricular hemorrhage is a very bad condition, carrying a high mortality rate, up to 80% in some published series. We know also that IVH is an independent prognostic factor of poor outcome. We know that in case of intracerebral hemorrhage, if also IVH is present, this increases the risk of death in a significant way. And it plays a role also in cases of subarachnoid hemorrhage. When there is a subarachnoid hemorrhage and more than 20 milliliters of blood in the ventricles, this can be lethal for our patients. And this is due to many reasons. Of course, the intracranial hypertension plays a major role as well as hydrocephalus. But there is also a chemical damage triggering an inflammatory response. This has been proved by previous publications. And there is also a direct mass effect very often when the blood invades the fourth ventricle. And this direct mass effect pushes against the brainstem with a subsequent reduced cerebral blood flow. And for all these reasons, we have a deterioration of the clinical situation of our patients. So there is a need for a reduction of mass effect due to blood. And we should do it as soon as possible. However, the most common treatment for this condition in all our departments is external ventricular drainage. External ventricular drainage has some pros. It is a very simple maneuver. It can be done by our residents. It allows for a fast resolution of acute hydrocephalus, for sure. However, we know there are also many cons. It frequently obstructs because of blood clots. So we have to replace the EVD very often. Sometimes one EVD is not enough. We have to place a bilateral EVD. And we have to wait a long time, days, to see the blood disappearing from our CT scans. And this has a consequence, a longer hospital stay and an increase of complications like infections, for example. Fibrinolytic therapy has been used to try to speed up the lysis process. However, we know that the irrigation with fibrinolytic therapy does not substantially improve functional outcomes, as it is clearly stated in the literature. Moreover, it is true that after a few days, we can see on the CT scan that apparently the blood is getting lysated, so less evident. However, there is a very nice publication by some Japanese colleagues, Yamamoto and colleagues, and they showed that even when we see less blood in the ventricles of our patients waiting or using fibrinolytic therapy, this does not mean that the CSF is clear inside the ventricles. The CSF is still dirty because of blood metabolites and lysates. So the only current way to get rid of blood from the ventricles is endoscopy. This is a preoperative CT scan. And this is the immediate postoperative CT scan after direct active aspiration of blood clots from the ventricles using a flexible endoscope. As you can appreciate, it's possible to remove the blood not only from the lateral ventricles, but also from the third ventricle and also from the fourth ventricle. This can be obtained using endoscopes. Of course, endoscopes can be rigid or flexible. There are some centers using a rigid endoscope. It's very efficient. However, it allows you to remove and aspirate blood from the lateral and the anterior third ventricle. For sure, you cannot enter the fourth ventricle with a rigid endoscope. This is allowed only with a flexible scope. Nowadays, it's possible, at least outside the European Union, to buy the very new video endoscope with the chip on the tip. In the European Union, unfortunately, they are not certified yet, so we have to wait. But in the rest of the world, you can have images which are as clear as those with the rigid endoscopes, and you have the benefits of a flexible endoscope. It's very important, in my opinion, to be able to aspirate directly the blood clots also from the fourth ventricle, because, again, from the literature, we know that fourth ventricular dilation is the most significant outcome predictor in patients with IVH, as published in the Journal of Neurosurgery several years ago. And the only way to get there is using a flexible scope, as we said. What about the outcome? We have published some papers during the years with our initial experience, and we show that it's possible, using this method, to not only reduce the Gripe score and the dilation of the ventricles, but also it's possible to reduce the mortality rate and also getting a quite favorable outcome in many patients, and apparently also to reduce the VP shunt dependency on our patients. I don't know why it's not possible to see the graphics. Let me see. Interesting. Do you see the picture here on the left?
Yeah.
I don't know why on the full screen it's not possible to see. Oh, wow.
Yeah, unfortunately.
Yeah, suddenly all the pictures disappeared. Let me restart the presentation, maybe. Don't know what's going on. Let's see. Okay. Okay, maybe. Can you see the screen now?
Yeah.
Okay, sorry for this technical problem. So a few years ago, our group published this paper showing the results about VP shunt dependency in our patients. We divided the patients into two groups, and historical, let's say, group, which is group B, including patients with IVH, treated only with EVD. And we divided all these patients according to the origin of the IVH. As you can see, these patients had an ICH associated with the IVH. These were patients with a ruptured aneurysm and so on. And group A includes the patients we treated with direct aspiration of blood clots with endoscopes. And the black bars show the percentage of patients requiring a VP shunt. And as you can see, there was a statistically significant reduction in VP shunt rates with patients operated with endoscopic aspiration and not EVD alone. In the literature, in the last years, some meta-analysis and systematic reviews have been published about the neuroendoscopic direct aspiration of intraventricular hemorrhage. And they are all saying basically the same things, that there is a benefit, a significant benefit for patients undergoing this kind of surgery. This review is the last one. It was published, it has been published this year. And this review shows that there is, in patients treated with neuroendoscope, there is a statistically significant reduction of shunt dependency compared to EVD alone. There is a statistically significant reduction of infection and a reduced length of stay at the hospital and ICU. There is also a reduced mortality at 6 months, and there is an increased functional outcome with this neuroendoscopic technique. And the technique is, of course, requires a training, but if you look at the instrumentation, it is a very simple instrumentation. What you need is a flexible endoscope and a pilloway to cannulate the lateral ventricle. Then you need a syringe to do the aspirations, connected outside to the operative channel of the flexible endoscope, and a pipeline for irrigation. As you can see, I use the operative channel as a sucker. What is very important is to place the bar hole in the proper position. Usually I stay precoronal, 2 centimeters precoronal, and not too much lateral, about 1.5 centimeter from the midline. Why I stay not too much lateral? Because when you enter the lateral ventricle, too lateral, the angle between your endoscope and the cerebral aqueduct is too big, and it is not so easy to enter the cerebral aqueduct. But if you stay not too lateral with the entry point, more closer to the midline, when you get into the third ventricle and you face the adytum of the cerebral aqueduct, it will be much easier for you to enter the cerebral aqueduct with a flexible endoscope. So the maneuvers when you are inside the ventricles are basically the irrigation and the aspiration. Irrigation helps you to unveil anatomical landmarks, to clear the CSF. And when you are in the fourth ventricle, irrigation is also important to balance the aspirated blood. Because when you are in the fourth ventricle, you have to take care not to induce pressure augmentation, as your endoscope basically occludes the cerebral aqueduct. So you are creating a trapped fourth ventricle, and you have to balance the aspiration and the irrigation volumes. And aspiration maneuvers, of course, are required to suck out the blood clots, as you can see from this picture here. So I want to show you the surgical phases of this surgery. Initially, as you can see, when you enter the lateral ventricle through the pilloway, the situation is very discouraging, very frustrating. I remember my first cases I have done alone. I had been trained by my mentor, Professor Longati, when I was a resident, but my first cases as a fully trained neurosurgeon were very disappointing initially, because all you can see is this red, dark red screen, no landmarks at all. But you don't have to be discouraged. You just need to do aspirations. Whenever you see red, you have to aspirate. And in the lateral ventricles, you can do strong aspirations because the lateral ventricles are very big. So you can aspirate in a very strong way, of course, until you see white. When you see white on the screen, it means you are facing the ependyma. And when you are facing the ependyma, you have to ask the second operator to stop the aspiration and to irrigate, to try to understand which part of the ventricle you are looking at. Quite soon, you will be able to detect the first important landmark, which is the choroid plexus at the floor of the lateral ventricle. As you can see here, there is the choroid plexus. And when you see the choroid plexus, then you feel much better because it's like a highway for you to follow all the way backwards to get rid of blood clots in the occipital horn of the lateral ventricle. And when you aspirate satisfactorily all the blood clots in the posterior part of the lateral ventricle, what you have to do is to follow the choroid plexus forwards. So you can move the tip of your scope forwards until you reach the foramen of Monro, which is this one. As you can see here, you have seen the fornix here. Of course, the foramen of Monro is full of blood. And what you have to do is to face the foramen of Monro and do the aspiration. And then you enter the third ventricle. The third ventricle has some landmarks, as we know, the mammillary bodies. Here they are. And in front of the mammillary bodies, we have the tuber cinereum here. And in front of the tuber cinereum, the infundibulum and the optic chiasm with the lamina terminalis. So in this way, you can unveil the anatomy of the anterior third ventricle. And then you have to move the tip of the scope all the way towards the back of the third ventricle, which is full of blood, again, of course, and do the same maneuvers. Aspiration when you see blood, red blood, and stop the aspiration and do irrigation when you see the white ependyma. Here you can start seeing the additum of the cerebral aqueduct. So keep removing the blood clots until you clearly see the posterior part of the third ventricle. Here you can see the additum and the posterior commissure, the abenular commissure. This is the pineal recess and the suprapineal recess, and even the roof of the third ventricle. Here you have a nice vision of the posterior third ventricle. After this, you can start navigating the cerebral aqueduct. Also in the cerebral aqueduct, there are some blood clots. You have to push the tip of the scope inside the fourth ventricle and start aspirating the blood clots from the fourth ventricle with the same technique. I want to point out that the third and the fourth ventricles are very small ventricles, so it takes a few minutes to get rid of blood in these ventricles. As you can see, you can detect the brainstem with the calamus scriptorius, and also, if you remove more clots, you can see the pica here, and the choroid plexus in the left Luschka foramen. Here you can see the calamus scriptorius with still some blood, and the choroid plexus going all the way to the right Luschka foramen, which is this one here. And then you can move your endoscope in the calamus scriptorius. You can recognize the facial colliculi, the opening of the central medullary canal here, the picas, and the two tonsilla of the cerebellum. You can enter the cisterna magna and remove, aspirate the very last blood clots. And in this way, you can observe the cisterna magna, which is free of blood. In this way, you have set all the CSF pathway free of blood. So now the CSF is free to flow in a physiological way. When you withdraw the endoscope, you can have a final look of the wonderful anatomy of the ventricular system. I always like to show this surgery until the very end of the exploration of the fourth ventricle to show that you can have almost no damage to the walls of the cerebral aqueduct navigating into the fourth ventricle. So with a flexible scope, which very nicely adapts to the complex geometry of the ventricular system, if you have a proper training, you can be quite safe. You can couple this technique with other techniques, depending on the origin of the intraventricular hemorrhage. For example, in cases of a ruptured aneurysm, you can treat the aneurysm. Of course, you have to treat the aneurysm first with coiling, for example, and then perform neuroendoscopy. Like in this case of pericallosal artery aneurysm, as you can see here with IVH, we coiled the aneurysm, and then immediately after securing the aneurysm, we did endoscopy, and in less than 1 hour, we were able to remove all the blood clots, even from the fourth ventricle, immediately. Or this other case is a case of basilar artery aneurysm, which also was coiled, and immediately after coiling, as you can see, there was a really huge compression on the brainstem in the posterior fossa due to the blood clots. And this is the result immediately after endoscopic aspiration of the blood. The blood can be removed from the third and also from the fourth ventricle. This is a clear benefit for the patients. Similarly, you can do clipping and neuroendoscopy. This was a 64-year-old male with a left MCA aneurysm. So I first clipped this aneurysm, and then this is the immediate CT scan. Aneurysm was clipped, apparently no complications, but the blood, of course, the blood is still there in the ventricles. So I took the patient again to the operative theater to do endoscopy, and this is the immediate result after endoscopy. There is a timing to do this kind of surgery. I learned from experience that if you wait too long, you will not be able to remove almost anything from the ventricles because the clots get more stiff and it will be impossible to suck them out. So my advice is to do this kind of surgery no later than 24, 48 hours after the bleeding. It's better in the first 24 hours. For sure, not after 48 hours. And also, I want to point out that at the end of my surgeries, I always leave an EVD in the ventricle because these patients are very often in an initially bad neurological condition. So I want to have a safety, drainage just in case. I leave an EVD, which is usually open but very high. And I ask my colleagues in the ICU to wake up the patient as soon as possible. So usually I'm able to close and remove the EVD in a couple of days, 2 or 3 days after a neuroendoscopic removal of blood. So to conclude, I believe that intraventricular hemorrhage is a very bad pathology, which is still treated in the same inefficient way since decades. And endoscopy has proved to be the most significant advancement to reduce mortality and improve the outcome of these problematic patients, especially using flexible scopes, which can allow you to remove clots even from the fourth ventricle. You can, as I said, improve the outcome, and also, as shown by the recent meta-analysis and systematic reviews, you can also reduce the VP shunt rates in these patients. As I said, of course, it's not the first a neuroendoscopic operation I recommend young neurosurgeons to perform. You need a training. There is a learning curve. This is, I believe, at the last stages of the learning curve, especially because you have to navigate all the ventricular system and because the vision is not clear due to blood clots. However, after a proper training, it is a safe procedure. And this is the reason why I am trying to push young neurosurgeons to be exposed more to this kind of neuroendoscopic techniques. Thank you very much for your attention, and of course, I'm ready to take any question. Thank you.
Thank you, Professor, for your excellent lesson, as always. And as a moderator, I want to ask one question firstly. And does neuroendoscopic treatment affect vasospasm in the patient with an supraacute hemorrhages in aneurysm patients?
Oh, sorry.
Okay, thank you. Yes, thank you for the question. It's a very good question, which I am not able to answer because we don't have enough data to assess this. I have no idea, actually. I think it has never been studied. For sure, I showed you what it is well known nowadays, which is removing the blood clots from the ventricles, decrease mortality, improves the outcome, and reduces the VP shunt dependency. I don't think anyone ever analyzed the rate of vasospasm. It's quite a difficult task, I think, because it requires, a prospective study. So I think there are no data to say that we can improve vasospasm doing this kind of surgery.
Thank you. And Dr. Selim Bozda, thanks for your excellent presentation. And question one, in cases where the intraventricular hemorrhage involves both lateral ventricles, do you perform septostomy to ensure bilateral communication and evacuation? If yes, what technique do you prefer and specific considerations to avoid injury to fornix?
Yes, thank you. Also, another very nice question. So initially, I remember when I was a resident and I was still training with my previous mentor, we performed the first cases placing two bar holes to remove blood from both lateral ventricles. But very soon we quit this kind of technique because we realized that we can use just one bar hole and then actually do a septostomy to remove the blood clots from the contralateral lateral ventricle. To avoid injuring the fornix, it's very important to remove all the blood clots from the ipsilateral lateral ventricle first, so you can have a direct vision of all your landmarks. And then when you are done with the first lateral ventricle, the landmark is very clear. It's a normal navigation of a lateral ventricle. Of course, using a flexible endoscope, it's safer, I would say, makes it safer to perform also a septostomy, in my opinion, because you are not pushed to a fixed direction, which is very vertical, like you are with a rigid endoscope. With a flexible scope, you just need to bend the tip of the endoscope, and then you have in front of you the septum pellucidum, and you can make the septostomy in a safe way. Of course, in general, but this is true for any kind of septostomy, I try not to stay too close to the fornix, and I try to be far away from major septal veins. That's it.
Thank you. And Professor Hasan Kamil Sucu says very nice videos, very impressive cases. You probably perform all your cases with flexible endoscope. Can a rigid endoscope be used for this purpose?
Yeah. It can. I know there are some groups using rigid endoscopes to do this kind of surgery. But with a rigid endoscope, you have to stop in the third ventricle. Of course, you cannot enter the cerebral aqueduct with a rigid endoscope. So uh, when I'm presenting my surgeries, these surgeries at congresses to other colleagues, sometimes some colleagues ask me, "Do you think it's good to perform this kind of surgery with a rigid scope?" So my question is very simple. I believe if you have a flexible endoscope, everything is much simpler, especially nowadays with the new chip on the tip flexible endoscopes. No damage if you have a proper training. I showed you, you can have almost no damage to the ependyma of the cerebral aqueduct, and you can actively remove blood clots from the cisterna magna and the fourth ventricle. But if you don't have at your institution a flexible endoscope, I think using a rigid scope to get rid of blood from the lateral and the third ventricles is more beneficial than EVD alone. So I think the ideal is to use also the flexible or couple the rigid and the flexible. Some people propose to use the rigid for the lateral and the anterior part of the third ventricle just to, speed up the process. The operative channel is bigger, you can go faster, and then use the flexible scope to navigate the posterior third, the cerebral aqueduct, and the fourth ventricle. That is the ideal situation. But not so many institutes have a flexible endoscope, so I think using a rigid in those cases is not ideal, but it's better than EVD alone.
Okay, thank you. Dr. Yunus Aydın, congratulations for a very didactic lecture. What is your plan for big intracranial hemorrhage associated with interventricular extension regarding the decompressive options?
Mhm. Thank you for the question. Yes, it happens sometimes. What I do in those cases is to balance, to try to understand which is the biggest cause of the compression of the intracerebral hypertension. And if there is a very big ICH, usually that is the real reason or the major reason for intracranial hypertension. So I get rid of the ICH with a bar hole and neuronavigation and a rigid endoscope. So for intracerebral hemorrhage, nowadays I really rarely use a craniotomy. I use a bar hole and a neuronavigation system to place the pill away. And in those cases, for ICH, I use a rigid endoscope, and I can remove a lot of blood, almost all blood of the intracerebral hemorrhage. And then after that, at least I can offer the patient a significant decompression. And then I perform a CT scan and I can check whether the ventricles are obstructed or not. So in case they are still obstructed, I eventually consider a second surgery, endoscopic surgery, to aspirate the ventricular blood.
Okay, one more question. Rigid endoscope doesn't allow access to the fourth ventricle. Adding a third ventriculostomy can facilitate CSF circulation and reduce the risk of persistent obstructive hydrocephalus. Do you think a meaningful benefit in performing ETV in this context?
Mm. Another excellent question. We have thought about performing ETV in our patients a few years ago. Uh, and we haven't because actually we have the flexible scope, so we trust the patency of the physiological CSF pathway. But if you don't remove the blood clots from the fourth ventricle, of course, you still might have an obstructive hydrocephalus, and probably, ideally, that can be beneficial for solving the obstructive hydrocephalus. But I want to point out that first, nobody has ever shown this benefit so far, so we need more data to prove it. And second, performing an ETV in a condition when you have a very unclear CSF because it's a bloody CSF. It's like moving in a foggy area, let's say. So if you do that, you must be very quite expert because it's not probably not a simple EVD. Landmarks can be not so clear, so it could be beneficial, but you have to pay attention to perform an ETV in this situation.
Yes. Professor Yunus Aydın says, I understood that you're not doing decompressive surgery, which covers bone flap removal and neuroplasty.
In cases of IVH, no.
No.
No, because if you can actively aspirate all the blood clots in the ventricles, at the end, I showed you the CT
Yeah.
scans. You have even air inside. There is enough decompression for the brain.
Yeah, okay. And Dr. Uday Bharti, this is not required in big ICH.
Okay, so we are talking about ICH. So if we
Yeah.
are talking about ICH,
Mhm.
as I said, I perform endoscopy removal with a rigid endoscope. So with ventricles, I use a flexible. And with ICH, I use a rigid endoscope, neuronavigated. In my experience, so far, I uh, I have never had to perform a decompressive craniectomy following the aspiration of blood clots for an ICH. But obviously, if it's not possible to remove sufficient blood clots of the ICH, or if there is, a very important edema, then of course, if you have to save the life of the patient, you can consider decompressive craniectomy. But if you are able to remove significantly the ICH, in my experience, it's not required to perform the compressive craniectomy.
Yeah. Dr. Selim Bozdağ, regarding irrigation during the endoscopic evacuation, do you prefer ringer lactate? Additionally, do you warm the irrigation fluid to the body temperature to minimize ICP fluctuations during continuous endoscopic irrigation? And
Yes.
how do you regulate irrigation pressure?
Yeah. Okay. So I do use ringer lactate because it has been showed that it is favoring intraventricular coagulation. I do use body temperature ringer lactate, yes. About the irrigation pressure, so there is a pipeline connected to a bag, which is placed quite high. So I use the gravity basically to irrigate. So it's a good pressure, but not so high, I would say. It must be the jet of ringer lactate coming out from the tip of the scope should not be very weak. Otherwise, it's not efficient to clarify your vision in front of you. It must be strong enough to, wash the CSF in front of you. Um, and as the diameter of the pilloway is bigger than the diameter of the flexible scope, I am not worried about inducing intracranial hypertension because whatever I irrigate, it comes out in the space between the endoscope and the pilloway, basically.
Okay. Dr. Udaybarti, uh, can we use aspiration catheter penumbra with flexible endoscope?
Mm-mm.
And
No, not with a flexible endoscope. The penumbra aspiration catheter, which was called Apollo, now it's Artemis device. It is possible to use this device only with, so far at least, only with the rigid endoscope and not with all the rigid endoscopes. For example, you can use it, and I use it sometimes with ICH to fragment ICH clots when they are too stiff, but you have to use the LOTA endoscope or the MINOP endoscope. If you have a little LOTA, it doesn't fit the working channel of the little LOTA, so not the flexible scope for sure.
what are your irrigation pressure with shrink? How many milliliters shrink do you use? With large ICH also, a mini craniotomy or endoscopic and hematoma evacuation is sufficient. Intracranial air and pulsating brain is required and endoscopic. DC is not necessary, says Dr. Davarti.
I agree. So about the syringe, I don't use the syringe for irrigation. So as I said, I for irrigation I use a pipeline with the bag placed quite high, and so I use the gravity to irrigate. Um, I use the syringe for aspirations. So when I face the blood clot uh, with the tip of the endoscope, I ask my assistant to use the syringe to aspirate. And he has to stop when a white appendum appears on the screen. Then I irrigate. I open, the irrigation and I unveil the landmarks. About large ICH, I totally agree. Yes, mini craniotomy or endoscopic evacuation through a bar hole is enough. In my experience, I have done both. In the last cases, I have always used the endoscopic bar hole because I can see I have very nice results. I can remove almost every clot inside the parenchyma, and the decompression is absolutely enough. I agree.
Yeah. And when active bleeding occurs during evacuation, do you use bipolar coagulation or do you prefer irrigation tamponade or hemostatic agents?
Mm. Yeah, thank you for this question, which is another important question. First, there is no bipolar coagulator for the flexible endoscope. There is only monopolar. But I don't use the monopolar coagulator. Very rarely I have to use. So in the majority of cases, when I have a bleeding, I do irrigation. Just irrigation, irrigation. Endoscopy is the surgery of patience. You have to be patient, not to be in a hurry. You just need to point the small vessel which is bleeding and irrigate. Sometimes I waited up to 20, 30 minutes irrigation. And then in more than 90% of cases, these bleedings stop. In a minority of cases, after 20, 30, because I am patient, but I am not, my patience is not infinite. So after 20 or 30 minutes, if it is still bleeding, which is this accounts for a very, very few number of cases. Sometimes I do compression with a Fogarty balloon, or with the tip of the scope itself, I get closer to the small vessel and I stay there against the small vessel. And in, I think, 3 cases, I had to use the dry field technique. which has been described by the group by Professor Schroeder. So I suck out all the CSF from the ventricles to operate on air condition, And in this way, the vision is much clearer because you are not you are not working in the dirty and bloody CSF. You are on air, which is clean. And just the contact of air, for some reason, lowers the bleeding of the source of bleeding. And in that case, I can more easily use monoporal coagulation to coagulate the bleeding vessel. But this is a really minority of cases, really minority of cases.
Yeah, okay. And Dr. Udaybarti, sir, can we combine any ventricular lavage procedure like urokinase? Dr. Schroeder is one of my mentors, he says.
Yeah. Well, Dr. Schroeder is one of the masters. Of course, I know him very well. Of course, everything is possible. Ventricular lavage with urokinase is another technique, but I have a different philosophy. I believe that with active aspiration, you are sure to remove all the blood clots immediately. So at the end of your surgery, which takes initially maybe 2 hours, but when you are a bit more experienced, I showed you in less than 1 hour, you are done with the surgery. And at the end of the surgery, you are sure 100% that the CSF pathway is free of blood. With ventricular lavage, you don't have this kind of feeling, and you have to wait because the lavage is not an active aspiration. First. Second, I used in the past urokinase in these patients, and in the last years, I totally abandoned urokinase because injecting in the ventricles something from the external area means you accept an increase of the risk of infection. And I believe if you can actively remove all the blood clots, you don't need urokinase. Again, if in your setting, in your hospital, in your institution, you don't have a flexible endoscope or not enough expertise, you are still at the beginning of the learning curve, and you don't feel like or you cannot do complete aspiration of the blood clots in the ventricles, of course, ventricular lavage plus urokinase is better than EVD alone.
Thank you, sir. As I see, there is no contribution or question left, and I want to give the floor to Professor Hasan Kamil Sucu.
Since we have finished all the questions and comments, maybe Dr. Udaybarti wants to say, and I have sent the request to turn on his microphone.
So I've asked my question. Thank you, sir. I've typed and asked.
Okay.
And one more thing that I have even also suggested this procedure to one of my senior professors here in India, and we also completely agree this will reduce the morbidity of the patients.
Yeah, yeah. I think nowadays it's very clear. A few years ago it was debated, but now we can say clearly that this procedure is beneficial.
And we also completely agree with you that DC is not required, and many cannot feel like evacuation is more than sufficient in large AC.
Yeah, yeah.
Dr. Udaybarti, also Dr. Selim wants your email address to contact with Dr. Schroeder. Maybe you can help us to contact him. Okay. Dr. Udaybarti. Did you hear?
Can you repeat? No.
Dr. Selim Bozda wants your email. Can you write?
I've sent.
Okay. Thank you.
Thank you.
I want to thank Professor Feletti It's very nice to see him again. We hope to see Dr. Feletti in Turkey, maybe in Italy.
Hopefully, yes. Yeah, both in Turkey and in Italy. Yeah,
Okay.
after two online webinars,
Yes.
probably time to meet in person. I agree.
Yes. Are you coming to Turkey sometime to travel?
Well, I have been to Turkey several times. I have friends in Turkey, so I have no plans to come in next few months. But we are not living so far away. Like it's from Venice, it's 2 hour flight, less than 2 hours.
Yeah, and is maybe springtime is a perfect time to visit İzmir, around İzmir. And okay, we will send
Nice.
you an invitation.
Thank you. Thank you. Same, of
You
course,
have
for
to buy
you.
your air ticket, and then we will handle the others. Okay.
Of course, that is not a problem. It will be a pleasure for me. Of course, you are also invited in Verona. Probably you have been to Verona before.
Yeah, we will come. Okay, promise.
Dr. Udaybarti has question.
Okay, also want to
Uh,
speak. Okay.
can we apply this technique to infants with IVH also?
Yeah. So it depends on the age, and because age means size,
Pediatric.
right? So I have done this kind of exploration in children, but not in infants. I believe in infants the anatomy is weaker, and if you suck out the clots, the brain can collapse. You have less space to move with a flexible scope, although it's very small scope because I'm using a 2.8 millimeter external diameter, but the brain and the ventricles of an infant are too small, I believe. So in those cases, we use, Omaya, and we use lavage. Yeah.
Yeah.
Okay. Thanks again. And I want to thank everyone who joined us. I want to thank Selin, Dr. Feletti, Dr. Uday. Thank you for your contributions.
Thank you very much. It was again pleasure and honor, really, and always it's really always very useful for me to discuss about these and other surgeries with all you colleagues. I found a very prepared audience with very smart questions. So thank you so much.
Thank you.
Thank you for joining us. Good evening.